My guest today is Dr. Maria Sophocles, a board-certified OBGYN, menopause specialist, author, and longtime advocate and pioneer in the quest for better women's health care. She has spent roughly 3 decades focused on menopause management, sexual health, and optimizing women's health span. Dr. Sophocles earned her undergraduate degree from Duke, attended Jefferson Medical College, and completed her residency at Johns Hopkins Greater Baltimore Medical Center. She founded Women's Healthcare of Princeton, and she now offers an exclusive concierge practice with long visits, on-demand access, and a focus on personalized care for women. She's also the author of the new book, The Bedroom Gap, which takes on one of the most neglected subjects in medicine and marriage: what really happens to women's sexual health in midlife, and why so many have been left to suffer in silence. I'm thrilled to welcome Dr. Sophocles to the postcast to tell us more. So, Dr. Sophocles, thank you for joining me. I'm so happy that you could spend time on my podcast. Of course, I want to let our viewers know how I know you. I know you, of course, as a nationally renowned women's health expert, the founder of Women's Healthcare of Princeton, but I'm also your patient. I've been your patient for over
10 years.
Yeah, 10 years now.
Counting.
That's right. So, and I remember the first time I came to your practice, and I'm sitting waiting for you to come in, and I look over and there's a beautiful glass case full of vibrators.
Yeah.
And I was like, wow, this is different. And also awesome, right? So I realized I was in a different type of a practice with a doctor who was going to take care of not just my pap smear, my annual exam, but me as a woman. Yeah. So I've always been a happy patient and I'm still a patient. And I wanted to just start by asking you, you were practicing standard OBGYN medicine for 3 decades, right? So what made you decide to expand your practice into women's health in general, and in particular, women's sexual health, particularly in perimenopause and menopause?
I mean, it was definitely a professional journey where I became a board certified OBGYN and thought, okay, I'm going to deliver babies and do surgery just like I was trained to do. And I did that. And then I started having patients asking me questions I wasn't prepared for. They would come in and say, I'm 42, I'm 48, and I'm emotionally a wreck. I tear up at everything. I have frozen shoulder. I have palpitations. I think I have depression. My joints ache. And I started thinking, gosh, I think these people need a neurologist, a psychiatrist, an orthopedic surgeon.
Right, I got to send them to a specialist.
I got to send them to all these specialists, not realizing I was failing them miserably. That almost all of these symptoms were due to the hormonal chaos of perimenopause or the hormonal absence of menopause. And so I realized that I had been inadequately trained, even though I trained at a really famous place.
Right.
So I went and got myself re-educated about menopause and said, okay, I'm going to start a practice that really caters. I'm going to give up the baby part.
Right.
There are other people here who can deliver babies just as well as I can.
Right.
And I'm going to focus this practice on gynecology and on things that are getting left out of traditional GYN practices: pediatric GYN, geriatrics, cancer survivorship,
Right.
people with chronic illnesses, people that were handicapped, people that were autistic, people that were getting sort of left out of the conversation, people who were transgender.
Right.
And so I started this practice 19 years ago, and it was wildly successful. It was the fastest growing practice that Penn Medicine had ever helped to start. And I think it was because it was meeting a need for women of all ages. And so that was wonderful. And I was really proud to have started that practice and to have offered menopause care 20 years before most people in America were really aware that it was going to have this great awakening.
Right.
The sex part came sort of afterwards because I thought, great, I'm doing this great job of helping women with hot flashes and mood stuff and period stuff. Mm-hmm. And then I started realizing that women were still feeling this shame sexually and that they didn't have anyone to talk to about it. They didn't want to go to a sex therapist. They didn't want to ask their primary care. Mm-hmm. They didn't necessarily feel right talking to their girlfriends about it in depth because they wanted help.
Right.
They weren't comfortable talking to their partners because in this country, we sort of learn messages from porn, from Disney, from pharma, from all these places, from Sunday school, from our parents, that sex is something for men. Sex is something men can talk about. Masturbation is something men can talk about and do. But for women, we're just not supposed to talk about it.
Right.
And I started realizing women have nowhere to go.
Right.
So maybe 15 years ago, I just started making sure I asked every single patient 2 easy questions. I thought I can make 30 seconds for anyone.
Right.
And I would say, are you sexually active and is it comfortable? And I was so surprised at the answers I got. People would say, no one's ever asked me that. And they would start crying and they would say, I actually have had major problems for 8 years and it's affecting my marriage. Or my partner had an affair because I've been sleeping in a different room for years. And I was stunned at how much came out of those 2 simple questions.
Right.
So again, I said, oh my gosh, I am inadequately prepared for this. And I found an international medical society called ISSWISH, the International Society for the Study of Women's Sexual Health. Big, long name.
Right.
And I started going to their conferences and learning about female sexual function and dysfunction and male sexual function and dysfunction. And I got trained as a sexual counselor. And I'm so glad I did because it's really been career changing for me, right? To understand the lack of adequacy in our society towards women's sexual health, that it is considered not part of medicine and nothing we want to talk about.
Right.
And I learned that because I realized male sexual health was being talked about by urologists to men and by primary care physicians. And this was largely because pharma had medications for them.
Yeah, that's right.
They had Viagra.
Viagra's been around for
all the Viagra buddies. And Viagra was at the time the most successful drug launch in history. Wow. It was like we were providing, penicillin again.
Right.
And it was rushed through the FDA and approved. And then Pfizer did this amazing marketing job with Bob Dole, telling men to find the courage to go to your doctor.
Right.
And it was brilliant. It was marketing gold. And men rushed in droves to their doctor saying, I'm allowed to ask you for this now, so I'm going to ask you for this.
Right.
And doctors were like, oh, I can be a superstar in your eyes. Here's your prescription.
Right.
And patients were like, I saw it on TV. Right. Write the prescription.
Right.
So while this was great, and I'm happy that men have this,
sure,
it actually backfired for women because couples used to sort of age out in parallel. And as the erectile dysfunction was happening, women were having menopause issues or vaginal dryness and loss of libido. And the couples were kind of this nod to each other. Hey, you've got issues. I got issues too. Right. I still love you. Right. And we can still cuddle. Right. Da, 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 da. So everyone was doing that in parallel as heterosexual couples.
Right.
But when Viagra came along, it sort of left women high and dry, unintended.
No, it's true.
And so this really struck me, that Viagra had created this gap in the bedroom. And that's where the idea for the bedroom gap started. I was going to call the book Viagravation because Viagra sort of created or worsened the bedroom gap. So I did a TED Talk and I said, hi, Ted, I think there's this issue and I think it's universal and I think we have to talk about it. And they
that
said—
was the impetus for your book?
Well, the TED Talk, I had thought about the book and I thought about it just being an article about how Viagra was widening problems in midlife for couples. And I wrote this article again called Viagravation, and then COVID struck and I was like, you know what? I don't think any magazine wants to hear an article about this. Everything was COVID.
Right.
So I put the article on my bookshelf, and then after COVID, I thought, maybe I could just give like a little talk and see if the world thinks it's important. So I pitched it to TED, and there's TED and TEDx, right? TEDx is like a community. There's been 100,000 TEDx talks. Correct. TED, there's only been 3,000 talks in the whole world in 30 years. So I was like, whatever, I'm just going to try for up there.
Right.
And they bought it. They said, yes, this is important, but you have to use humor. We love that you like humor and we want you to use humor. I was like, I can do humor. So I gave the TED Talk and it got like 1 million views right away, which is nothing today. But anyway, for an older woman, I guess it was I was like, yay, that's a lot.
That's successful, right?
And it made me realize I should go back to that article and see if it's a book. So I started doing research on sexual health and sexual dysfunction, and not just what happens, what I saw as a doctor,
Right.
Loss of estrogen, loss of blood vessels, breakdown of collagen, women coming in saying it hurts,
Right.
I don't have libido. I kind of knew that as a doctor. But I started looking back to history and to culture and to societies that define that sex is for men. And where did all this come from? And it's been around for thousands of years,
right?
Forever. And I started realizing those women that were coming into my office saying, I don't have libido, or I'm broken, or it hurts, they were feeling shame because society was telling them,
Right.
you have to stay sexually vibrant, you have to stay Instagram perfect, you have to really know sex and be good at sex. And Hollywood tells you you have to have an orgasm after 3 seconds.
Right.
I hope it's okay that this isn't G-rated.
It's definitely viewer advisory, no worries.
Okay. And I started thinking, God, that's awful.
Right.
That these women feel they owe their partners this. Like,
Right.
do you really owe someone something, or do you just owe yourself
Right.
good health and happiness and pleasure? That's really what I wanted to get at. So the more I researched, the more I was like, this is a book. This is not an article. This is a book. And I think it's a book both men and women need to read.
I agree.
Gay and straight.
I agree.
And even men and women of all ages. Like, I can't tell you how many 25-year-olds come to my lectures now. And I'm like, what are you doing here? This is for midlife. And they're like, I need to learn this now.
Well, and I think that resonates, because if you're talking about just sex ed, right? Sex ed at school or through high school,
I mean, they don't get real good sex ed.
They don't. It could be better. But also, sex ed is about your lifelong journey with your.
Well, sex ed in high schools is about putting a condom on a man.
And that's important. Yeah, that's important too.
It is.
But all women are going to, if you live long enough, you're going to go through perimenopause and menopause.
Absolutely.
And why wait until you're in it to learn about it?
That's right. So the book became, I've got to teach people what happens in perimenopause and menopause, physiologically, functionally, anatomically.
Mm-hmm.
I have to make sure women and men know what the parts of the body, basic stuff.
Right.
They have to know not to have shame about the changes that happen. They have to know how pleasure happens. And even if you don't have a partner, try to have pleasure yourself. So it had to be kind of basic. I had to make sure there were scientific stats in there, because I did do a lot of scientific research for this, and I want people to know this isn't just my ideas.
Right.
But also, it had to be readable. It had to be fun and funny, and yet also address things that are really serious and intimate. So it's a little bit of everything.
It is. No.
How did you find it?
I loved it. So I listened to the audiobook version.
Good.
Which I want to tell our viewers is so wonderful, because you narrate it. Mm-hmm. And I think that that's really important for a book that's touching on sex, sexual health, sensitive and medical topics, being narrated by a doctor. So you do inject humor, you do inject the facts, and it's also comforting. The way you talk to the reader or the listener about these subjects is compassionate, understanding. You can tell you've been doing this a long time and you're knowledgeable, but it's also kind. So I think when people pick up a book like this, wherever they are, whether they're a young person wondering what is perimenopause going to be like, or if you're someone my age who's already postmenopausal and is having issues, the book is, I think it's revolutionary, really. I think everybody should read it, men and women, to really understand something that we just don't talk about enough in society.
Mm-hmm. And to give people permission to want to be curious and to want to evolve sexually.
Right.
I mean, if you think about it, we take tennis lessons and pickleball coaches and private trainers, and we evolve as adults.
That's true.
And we're proud of the fact that we've learned how to be great at mahjong or whatever it is. We're getting better and better. And yet sexually, the opposite happens. We're supposed to already know how to do it. Right. We start doing it. Who tells you, by the way?
Right.
Except your uncle's Penthouse magazine, right? Some foreign something to watch with your cousin or something. So we're supposed to already know about it. We're supposed to be good at it.
Right.
And yet many couples, unfortunately, I've learned this, kind of get there and then they just stay. They don't evolve that much and they don't talk to each other. They don't say, what do you like? Or what works for you? Or what can I do better?
What could we try? Would you be interested in this, right?
I mean, some do. I don't want to say none do. But, and midlife is sort of this pivotal part where I think of life where people suddenly go, oh, wow, I've been busy for 20 or 25 years, raising kids, developing a career. Like now I'm either single, widowed, divorced, or partnered, right? Whatever you are. Right. And I've got a few decades left until things start getting kind of falling apart.
Yeah, that's right.
And I want to have joy and I want to have pleasure. I want to have sexual pleasure maybe. And surely I've never had it. And also I want to have health. And we forget that sexual health is actually about your heart of health.
Right.
When I lecture on longevity and overall health optimization, we talk about 4 pillars of health: sleep, nutrition, movement, social connectivity. Right. Sleep, so food, nutrition or food, movement or exercise, social connectivity. These are 4 key things to really age well. Whether you're starting this at 30, 50, or 70, you want to focus on those 4 things. Right. Don't worry about meds and supplements and anything else. I mean, it doesn't mean you may not need medications or want to take supplements, but if you get those 4 things in order, you're setting yourself up for success. Right. But I argue that sexual health is a thin silver. It is. If you have sexual health, you have connectivity to someone. Right. You build intimacy, and we know that intimacy is actually linked to longevity, right? To longevity.
That's right.
So I think it's not crazy to think about that. Many people are like, I don't need it. I can do without it. That's fine. You can also do without exercise. But we know that people who exercise eat better, feel happier, they have more energy. You can say you can do without any of that.
Sure.
But you pay a price. So I guess I do believe in that. I think my patients do. My patients who've taken that journey with me to say, I'd like to reset, I'd like to reframe, or I want to work on how my relationship is sexually. Right. I want to give it a little attention and work.
And that is, it's a kind of you could call it a midlife crisis. It's very common at that point in life for an evaluation, right?
Yeah.
So when you have women in perimenopause or menopause come to you for medical care, and then they begin to discuss what's going on with them. What do you see as the biggest challenges for women? What do you see as the biggest complaint they have or worry that they have when they come to see you?
Well, I think we have an incredible lack of information in this country about perimenopause and menopause. We're closing that gap rapidly. Influencers, doctors, people are taking to podcasts and Substack, and so a lot of people now know, wow, we were fed incorrect information 23 years ago by a study that was misinterpreted, and it linked estrogen and progesterone to cancer. And once it did that, it did enormous damage. We've now calculated how many premature deaths have occurred in America in the last 23 years because of that study.
Wow.
Yeah, and it's stunning. We've linked it to 150,000 premature deaths.
Oh, that's
from women who could have taken estrogen and progesterone and then not gotten osteoporosis, had a hip fracture, and died.
Right, because cardiovascular illness.
Cardiovascular disease, #1 killer.
Right.
Dementia, Alzheimer's, urinary tract infections. I mean, when you add plus the billions to our healthcare system that we've added by keeping women from all that, but that is changing.
Right. So I was really interested to read about it, and I wanted you to talk about the recent removal of the black box warning on estrogen as hormone therapy.
Yeah. So when I was trying to get myself better informed about menopause, maybe 20 years ago, I joined what's now called the Menopause Society. It used to be called the North American Menopause Society. And I learned there that this tragedy had happened about the Women's Health Initiative being misinterpreted. And I learned then that not only did estrogen and progesterone not cause cancer, but that women who use estrogen or progesterone after they stop having periods have a 30-something% lower risk of breast cancer, a lower risk of colon cancer, lower all-cause mortality, longer lifespan. So exactly the opposite.
Of what the study said. Right?
And we now have many, many, many studies showing that, which is great. It doesn't mean there are no risks. It doesn't mean there are no side effects.
Right.
And it doesn't mean that it's for everyone. So 2 types of women only cannot take systemic estrogen or progesterone. Number 1, you have undiagnosed vaginal bleeding after menopause. You cannot take this until your doctor gets an ultrasound and makes sure everything's okay.
Okay.
But that's obvious. If you're bleeding, you're going to call me.
Right,
I know you are. Right. You know I'm going to get that ultrasound ASAP.
Of course.
The second, probably more important group of women that absolutely cannot take and should not take estrogen or progesterone are women who have an estrogen-sensitive breast cancer or even uterine cancer.
Right.
A cancer that if we give you estrogen, it can recur or get worse.
Right.
Should be a no-brainer, but that's what that is.
Sure.
But people come to me all the time and they say, well, my aunt had breast cancer, so isn't that the same? No, it's not the same at all.
Not at all.
Your aunt is not you. Right. My mother had breast cancer. I'm really sorry she did. That doesn't mean you can't take it.
Right.
So family history does not mean you can't take it. Okay? It may raise your own risk for it. It doesn't mean you can't take it.
It's important to know.
It's important. Yeah.
So when you are treating women now, knowing that this severe warning is gone from the FDA, do some women breathe a sigh of relief? And then
some are still scared. They say, why was it on there in the first place? And I explained it was on there in the first place because of something called class labeling. And that means if there's a warning for one estrogen product, they have to put it on every estrogen product. So there was even this dangerous, scary warning saying increases risk of dementia, stroke, uterine cancer. That was even on vaginal estrogen, which doesn't go anywhere.
Right.
That can't cause dementia or a stroke. And if you had a stroke, you're safe to take it.
Right.
If you have dementia, you're safe to take it.
Right.
If you had breast cancer, you're safe to take it. Right. And by it, I'm talking about vaginal estrogen.
Right. The difference between systemic.
Yeah. So there is a big difference. There's no one who's not safe for whom vaginal estrogen.
Right. And that's really, it's important. And I'm convinced that people just don't know it. Women just don't know that these options are available to them.
And they don't know the difference between a patch or a gel, which is systemic, and vaginal estrogen, which is local. Hugely different. And my TED Talk has a little animation in it. So
explaining it.
Definitely, if you Google TED Talk Maryann Sophocles, you see some beautiful animation of a woman and what the difference is.
Right.
You also see an animation about what happens vaginally when we take estrogen away in menopause.
Right.
You see thick, ridgy pink tissue become yellow, pale, dry. And I think that visual is really important because it shows us that when we go into menopause, the bladder and the vagina really suffer, and they suffer chronically and progressively. And this is why helping with either vaginal estrogen or a CO2 laser will restore health, and you can keep it. So you can be 57 and come into my office and say, I've been really bad. I haven't done anything for 7 years. My girlfriend told me not to use vaginal estrogen.
Right.
And I can say, no problem. Give me 3 months.
Start now.
And we will use this laser or use vaginal estrogen or combine them, and you will regenerate that tissue. That's pretty cool because
it's
not
so
much in the world can we go backwards.
Right.
You know.
And then in addition to estrogen, do you also then prescribe the other hormones that are missing when women enter menopause?
It depends what they need, right? If you come to me and you say, so there's 2 reasons to take HRT only. Number 1, I'm having symptoms. I'm having hot flashes, my memory, my joint pain, whatever. Help me. Okay. We can give you estrogen. If you have no uterus, you just take estrogen. Or if you have a uterus, estrogen and progesterone. And we do that systemically, with a gel or a patch. And the progesterone's a pill. The second reason is for what we call in medicine preservation of function, which is code for keep my arteries clean, keep my brain functioning, and keep my bones strong. And you can do that for that reason alone. If you have no symptoms, but you just want to stay ahead of the health curve, I would urge you to use HRT for a minimum of 10 years.
Right.
We know that the first 10 years out, like age 50 to 60, that's the most critical time.
Okay.
That's the most benefit you can get.
That you can get.
But we're even doing research now looking at women taking it from 60 to 70. And shocker, we're finding it helps. We're finding it keeps your bones strong.
No matter when you start it.
No matter when you start it. But ideal is start right away.
Okay. So can we talk a little bit about testosterone for women? Because as much as I thought I knew about this until I read your book, I did not realize that it is not FDA approved for women as hormone therapy. I was a little shocked.
No, it should be.
It should
But
be.
it's not. We have gendered our hormones in this country. We, the FDA, someone decided that men make testosterone, and that's a manly hormone, and women make estrogen, and that's a feminine hormone. But it turns out that even when we're in our mom's bodies growing as a little fetus, we make both estrogen and testosterone, whether we're male or female.
Right.
And even as a little girl, you made testosterone. And you made testosterone all the way until you became menopausal and your ovaries stopped making estrogen, progesterone, and testosterone. So you lost all three.
Right.
So theoretically, we should replace all three.
Right.
But because of this old-fashioned genderization, just like women don't wear pants, they wear dresses and skirts. Well, thank God we figured that one out.
Right.
But women need testosterone. You need it in your brain. You need it in your bones. You need it in your genitals.
Right.
So right now, because we're still behind the times, if I want to help you with testosterone, I have to call a compounding pharmacy and say, please make up this little tiny female dose.
And it's not covered by insurance?
It's not covered by insurance.
It's
but
amazing.
Male testosterone, we have 34 different male testosterone products that men can take. So they're set and it's covered by insurance. But we are working on it. Advocates like myself are fighting really hard to get testosterone FDA approved for women. So give me 5 years or so, we'll have it. We'll have it. But right now you have to either use a male, I can order the male stuff for you and just have to teach you how to do a 1/10 of a dose.
Right.
It's a little bit annoying. So we're getting there. And we use it both a little cream on your leg that goes systemic, and that helps libido. That's how we mostly use it.
Right.
Or we can actually use it on the genitals to revamp and make new blood vessels and new nerve endings.
It's amazing.
Kind of cool.
It is things that people don't know.
They don't know. They don't know. And the sad thing is most doctors don't know this. So that's the sort of, I haven't talked about that on this podcast. But
I would like you to talk about that because it is such a societal problem in general where if we are going through these changes in midlife and they're personal, we're not always comfortable even talking to our own sister or a girlfriend about changes down there or what's happening in the bedroom.
You could go to your doctor.
You want to be able to go to the doctor, right? Except if you do, and they're not knowledgeable and they can't help you, then you really feel lost.
And guess what? Most physicians, PAs, nurse practitioners are not trained in menopause and not trained in sexual health, which is really another form of sexism in this country. The fact that 50% of our society is female and 100% of women go through menopause. 100% of people born with a uterus
are going to go through it.
Right. Why? What is menopause? It's when the ovaries cease to function. And in America, the average age is 51 and a half. So we live over a third of our lives without ovarian function. We literally outlive those organs.
Right.
And as soon as they stop functioning, we have loss of elasticity in the skin and wrinkles develop. We have a loss of nice fluid in our joints and we get arthritis. We have changes in the heartbeat and we get palpitations. Not everyone gets this, but so many different things.
Right, so many different symptoms. Right, when you compare with your girlfriends who are headed towards menopause or in menopause, I'm always shocked at the variety of symptoms. Oh, well, I have trouble sleeping. Well, I don't. Well, my hair is thinning. Well, mine isn't. The weight gain, that seems universal.
But it's not so much weight gain. It is weight gain, but it's a redistribution of fat. It's a preferential deposition of fat in the abdomen.
That's right.
Thank you for nothing. You invented that one. And what planet? We need to do new fashion tips, which is, by the way, if you have a little belly, that's sexy. Because mostly we don't consider that. And that happens because the ovaries reduce their production of estrogen and testosterone, but the estrogen falls even more than the testosterone. So metabolically we change, and when our metabolism sees relatively more testosterone, it says deposit on the belly, more like men.
That's what happens.
That's where men deposit fat, right?
Right.
So we get this almost male shift.
Right.
It's really frustrating. It's really common. 85% of women have unwanted and unexplained fat on their belly.
Exactly.
Same percentage of women who have dysfunctional sleep. So a lot of perimenopausal and menopausal women have trouble sleeping. That is estrogen leaving the brain. And our poor little brain just says, I don't sleep well anymore.
Right.
It's really frustrating.
So in talking about sexual dysfunction in women and the apparent lack of a solution for women similar to Viagra for men.
Right. Why is that so under the radar?
Right.
Well, it started out not under the radar because when Viagra was so profitable, Pfizer immediately said, we got to do this for women. Right. So they did all the studies giving women Viagra, and unfortunately, it just doesn't work. We don't need erection help.
Right.
We don't. That's not
going to work.
We do actually have a little erection, but that's not what we need.
Right.
Women need help with desire. That's the number one sexual complaint women come to my office for is I don't have desire. Just give me desire.
Right.
And the first thing I do actually before I ever say, good, I can write you a prescription. That's actually the last thing I do.
Okay.
And we'll talk about the meds that are out there. But first we have to understand what's the deal with your relationship? What's the deal with you?
Right.
Your body? Are you comfortable in your skin?
Right.
Where did you learn about sex from? Your parents? Sunday school? You know, are you ashamed of sex? Are you sexually progressive? Have you had lots of partners? Why do I need to know that? It's not that I'm curious. It's that it helps me understand, can I help you? I mean, is your mother-in-law living with you in the bedroom?
Right. This would be any number of factors.
Does a dog sleep in your bed? Does your 6-year-old sleep in your bed?
Right.
I mean, there are things that are a setup for sexual problems. Does your husband snore?
Right.
If he snores and
you're in the other room.
Yeah, you're in the other room, or are you in the bed just not sleeping well?
Right.
If you're not sleeping well, guess what? You don't wake up the next day and go, I can't wait to have sex.
Right.
You're like, I can't wait to go to sleep.
Right.
It's true.
It's true.
It's true.
It's true.
So I think some basic things, you know, are you so stressed about work that you lie in bed like this?
Right.
Is your bedroom full of dirty laundry and computers? And are you binge watching something at 11:30 at night?
Right. That's not setting the scene for sex.
Or is your bedroom a place of rest? A place where you can be mindful and clear? Like I was so lucky to study under Ruth Westheimer, Dr.
That's amazing.
I was really blessed for that.
Yeah,
and she, in her cute little accent, told me, you know, Maria, the bedroom must be for only 2 things, sleep and sex. And I was like, yeah, right, that's so obvious. No, it was brilliant.
It is brilliant. It really
We
is.
live lives where we can be on our phones and available and Zoom call in any room, anywhere.
It's true.
And it's made the bedroom for work also.
Yeah.
And I think we are depriving ourselves by not listening to Dr. Ruth and not saying, right, I need my bedroom to be where the rest of the world doesn't get to come in.
Yeah, that's excellent.
And whether it's just me and my toy,
Right.
or whether it's me and a partner, I need to value that.
Right.
And we don't. We might pay lip service to it.
Right, but we don't actually do it.
We don't do it.
But that's your evaluation of your patient as an entire person. It's what I've always appreciated as being a patient, that you're looking in their history to help understand how you can help them in the present and the future. Right? Because without all that, we're all so different.
You're a product of where you came from.
It's so true.
Whether it was a traumatic sexual event or a wonderful lover who was patient and taught you about pleasure, or parents telling you never, never, never touch yourself, you know, whatever it is.
You carry it with you.
You carry that. Or a bad marriage.
Right, of course.
And so internet dating has become something I had to really go deep on and learn about, because it's positive and negative. My patients were terrified of it. If they've only had one partner, now they're 48 or 60.
Right, how am I going to meet somebody, right?
Or they're using it as a way to grow sexually, which is pretty cool.
That is.
Right? I only had sex with my husband for 22 years, and we always did it this way, and that's all I know.
Right.
Now they're dating and they're meeting men or women who can grow them a bit.
Right.
Teach them about fantasy, can teach them about kink, can teach them about bisexuality, you know, whatever
it is.
Right. And if you don't want that, that's fine. You can look and swipe left or swipe right. And find something that's just what you want. But for some people, it's really a renaissance.
That's true.
A renaissance. So I think it serves its purpose. Absolutely. I think porn serves a purpose too. And that's a very unpopular stance because I myself wince when I think about the word porn.
Right.
Because most of porn is through the male gaze, for profit, increasingly violent, demeaning. The two most common words women are called in porn, bitch and slut. That's not cool.
No,
I
that's
don't think.
awful. No.
But there is a flip side, which is for some people, let's say you and I are newly divorced, and we want to explore what else might be out there for us. There is now a budding women-friendly porn, right, by women directors. They think about what would women want to see. They're very sensitive to that. It's not always easy to find. You know, you can go on Pornhub and you're first going to get hit with 500 things you wish you'd never seen, and midgets and whatever. But there are sites, and I usually will discuss this with my patients when they come in. I'll say, this is a really cool app, right, where you can put headphones on and someone will read you an erotic story.
Right.
This is a cool site of videos that are sort of female friendly.
Right.
And women are
Yeah, they're shocked that it's out there, right?
What?
They probably never even considered to go look for it.
That's right.
And there it is for them.
So back to what you were asking, how come we don't know about meds for females? Well, number one, there aren't that many.
Right.
And number two, they're not super well marketed. They don't even have the marketing budget, you know, because remember, a lot of investors don't think female and sex should even be in the same category. So until we get more women VCs,
Right.
and private equity firms that
Are willing to put the money
say,
into it.
yeah, maybe you and I will do that.
Maybe.
You know? There are 2 different medications that are FDA approved.
Okay.
The first one was approved in 2018, so pretty recently.
Yeah.
But it was only approved for pre-menopausal women. How nuts is that?
That's crazy.
After menopause, you probably don't even want sex, right? Wrong. So us really do.
Yes.
It was reapproved for postmenopausal women just in December. Just 3 months ago.
Really? Mm-hmm. Okay, well, that's good.
Yeah. So that medication is called ADDY, ADDYI. And it works a lot like an antidepressant, meaning it works in the brain on neurochemicals in the brain to sort of help you have a little more desire. So you take it every day, and this is where some people go, forget it, I don't want to take a medication every day. But you know what? Sometimes you got to pay to play.
Right.
Take it every day. You take it at bedtime.
Okay.
Most common side effects are some sleepiness, some nausea, some weight loss, which most women don't mind.
Right.
But if you take it at bedtime, you don't really notice the sodium extra. So it's very well tolerated. It's very safe. It really is. It's great. And it will increase the number of sexual acts you perform every month because you have a little more interest.
That's great.
It's kind of that simple.
That's great.
The second medication is a little different. It's almost more like Viagra, even though it has nothing to do with erection. You take it on demand.
Oh, sorry.
And so you take it about 45 minutes before you want to be sexually active.
Okay.
It works also in the brain, and it causes a pretty impressive release of dopamine. And dopamine is like our feel-good,
Right.
neurochemical that, you know, when we get lots of likes on Facebook or Instagram, it's like, ooh, dopamine hit,
Right,
you
right.
know. And this is a really big dopamine hit.
Wow.
It's an injection a lot like Wegovy or Mounjaro or Ozempic. So it's a little tiny pen. You really don't feel it.
Right.
I know the needle itself, and it's tight. And you inject in the tummy, and it lasts for about 15 hours.
Wow.
So if you're going away for the weekend, or you're going on a cruise, or you want to have sex that night and wake up in the morning and still really feel great,
Right.
it works. It's called Vyleesi. I don't know who names these. Vyleesi. Can have some side effects, especially the first time. Not dangerous ones, annoying, I would say. So I talk to women all about that. We make a plan for that. And honestly, they're really psyched about it.
Wow.
But most doctors have not even heard of these two. And when they hear, many doctors are like, I got to worry about blood pressure and mammograms. I don't have time for this.
Right.
So some of it is they're kind of dismissive about it.
Right.
So I'm hoping the new generation of clinicians that in medical schools will say, look, guys, this is important. And when they're going to ask about this, and you owe them to know about it.
Right.
That's one of my little missions.
No, I think that advocacy is so important.
Yeah.
With the public and with other clinicians.
Right.
Because the more information that is out there, the more we can help women. Again, I consider myself knowledgeable. I like to read a lot. I've been your patient all these years. I did not know about those medications.
Yep.
And I thought, well, if I don't know about it, a bunch of other women don't know that it's an option.
Right. We need to approach this in two ways. We need women to know about it. So you will go to a clinician and say,
I want
this,
this.
or I want you to help me with my sexual health.
Right.
Okay, you don't have to be ashamed to talk about sex to a clinician. You say sexual health. Hey, my sexual health is suffering. My relationship is suffering. My self-esteem is suffering.
Right.
And I want help with it. And if you're dismissed, then you know that clinician is not knowledgeable and not comfortable talking to you.
Right.
And it's okay to go find another clinician. You can go on menopause.org.
Okay.
And put your zip code in and find a clinician who's menopause.
That's a great resource. Yeah.
They may or may not be comfortable talking about sex, but at least they'll understand about menopause.
Right.
Would be comfortable giving you vaginal estrogen.
Right.
You can go to iswsh.org and see if you can find someone through there.
I mean, excellent.
So you can put those in show notes.
Yes, absolutely. It'll
Because we need to help women find clinicians who are comfortable.
Right.
And find the courage to bring it up. And then over the next 20, 30 years, we need a whole new generation of clinicians.
Right. Well, and that's why when we started talking today, I mentioned being a patient and how surprised but delighted I was to see that you were clearly going to take care of my sexual health and everything about me as a woman. And then you continue to do that. So I wanted to segue into a discussion of your concierge practice because a lot of people don't know what that is.
Yep.
And I'll give an anecdote if that's okay.
Please.
So back in December, I found a lump in my breast and it terrified me because my mother had breast cancer. My wife has suffered breast cancer. So I was very nervous and I called your office as a patient. The nurse picked up the phone right at 9:00 and I'd like to see you at noon that day. That's unheard of in any standard GYN practice. The relief that I had that I could be examined, that you immediately wrote me a script for a mammogram, and off I went for diagnosis. And thankfully, it was benign. That's an example of what a concierge practice can provide. But I wanted you to be able to talk a little bit more about how you serve that way.
How I'm practicing now is how I kind of dreamed of practicing for many years. But our healthcare system's pretty broken. Mm-hmm. And when COVID happened, a huge number of physicians retired. And so it left a real deficit nationally in terms of availability of physicians. New Jersey, less. It's a very populous state. And still, we suffer from doctors having, patients having to wait 6 weeks, 6 months.
Right.
And when you have a lump in your breast,
there's no waiting.
Right. There's no waiting.
Right.
So even when I took insurance for 29 years, and now in my 30th year of practice, I gave myself a present and said, I want to practice medicine the way I would want to be as a patient. I honestly accept very few patients, but I go very deep with them and we do backflips to care for them in whatever way they need, whether that's helping them find a kidney specialist who specializes in stones,
right,
or find an esthetician who understands about microneedling.
Right,
I mean, that's
right.
not silly and not medical, but
it's still important to it.
I feel that I view them as a whole being, that they're not vain just because they're asking me if I know how to get rid of wrinkles,
of course,
and that they're not vain because their hair is thinning and they want to know about that.
Right.
I can help them understand the hormonal basis, but I'm also happy to say, but you don't want me fixing that. You want this dermatologist,
right. So
you want this esthetician, or you want this preventative cardiologist. So we go very deep. I was a researcher in cholesterol many, many years ago. So I do feel very deeply about women's cardiovascular health. It gets neglected by OBGYNs, and thus it shouldn't. So I go very deep with that, with bone, with bladder, with sex, with all this stuff. I just feel that you need a place as a woman, especially a midlife woman, where you can be head to toe really evaluated and cared for.
It's so important. All of those specialists, and then also for weight management.
That's
right. When we're talking about menopause and we're talking about that unwanted belly fat or unwanted weight anywhere, you can help with that as well.
Yeah, I was very lucky. I've always been kind of an early adopter of things. Right. I like to be progressive. I just feel that if we wait around for a medical society to approve something 10 years later, that's 10 years that you can have plaques building up in your arteries,
right,
or something like that.
Right.
And that progressive attitude happened because of something in my own family. My grandmother had a heart attack at 48.
Wow.
And luckily, she was taken to Johns Hopkins, and they were very progressive. And they said, hold on, 48-year-old woman's not supposed to have a heart attack.
Right.
Let's check your cholesterol and that of your children and your grandchildren, because she had a 7-year-old granddaughter.
Yeah.
And sure enough, we all had sky-high cholesterol.
Oh, wow.
So I was lucky to be diagnosed at age 7 with genetically based high cholesterol,
Wow.
which is totally treatable.
Right.
So I've been on medication since I was 7, and my arteries are clean, and I will live a nice, long, healthy life.
Right. This has
Whereas
been
had I
treated.
not been diagnosed and waited to have chest pain at 50 or something.
Right.
Right. So it always made sense to me that our medical system diagnoses problems after they happen and then treats them. And I've always believed that we should be prevent. We should aim to have our patients not get the problems in the first place.
Right.
It's a simple difference, but it means a lot.
It does.
So that's how I've always tried to treat my patients. But taking insurance, it's challenging because you get reimbursed so little money that you have to do it all in 15 minutes. I just never felt I could do a good job.
No, and yours is not a 15-minute visit.
No, they're 60 to 90 minutes.
Exactly.
Partly because I talk a lot, but also because I love, honestly, it's selfish. I love my patients, and I want you to leave saying, I feel supported.
I was helped. Right.
Yeah. So this past year, I just said, I'm going to take this big practice with 30,000 women, and I'm going to gift it to a healthcare system,
Right.
so that other doctors can come in and take over for me, and nurse practitioners, and they can continue to serve people in that way. But that I want to have something where I can go as deep and as well as people need. And I think I'm going to probably expand it so that we can see more women, because it's been a tsunami of interest.
Oh, wow.
And that's good.
Oh, that's a good problem to have.
So I have a brick and mortar practice in Princeton. I see patients in New York. I'm licensed in 11 states, because once the TED Talk came out, people from all over the country contact me.
Right.
And so this way I can help them. But I think I want to have, someone else there so that they're more available to this community. Because I want the Montgomery community to come.
Yeah.
And the Skillman community and
Princeton and surrounding, right? I want to know about it.
I do. I don't want, if you are getting dismissed, or if you're having menopause issues or vaginal pain or pain with sex or sexual issues, I want you to get there, and I want you to have availability. So I love it. I feel really honored to do what I do. I mean, I love it. I literally
I can tell. No, it's wonderful. So one of the things actually that you and I have spoken about that was so fascinating that is not in your book is some of the very early research on addressing menopause in such an interesting scientific way to prevent it or slow it down from happening at all. Can you tell us a little bit about that?
Yes, I'm so lucky. My husband is in biotech.
Okay.
And so he gets to see companies that are developing things that you and I can only dream about. Real cures for cancers, or cures for muscle wasting diseases, or things that right now doctors say, I'm sorry, there's no cure.
Right.
So he gets to see all these companies, and he's on his 9th company, and I get to come along for the ride and learn. And I go to these conferences, and I started seeing more and more things for women. There was nothing for women. Everything was for diabetes and cancer, which are important.
Sure.
But slowly we are seeing money being spent to look at women's diseases like endometriosis, and really trying to prevent them or fix them or help fertility, things like this. I mean, this should have been happening decades.
Right.
But one of the things that really caught my eye that I think is mind-blowing is there are at least 2 companies now. It's almost like Indiana Jones racing to find the whatever he was racing. Right. You're like, oh my God, if he finds this is got to be unbelievable. Trying to find a way to have the ovaries not stop functioning. So we would not experience menopause and all the hot flashes and all that, which would be awesome.
It would.
But also not experience the really decay of our bodies.
What's the resulting health problems?
The cardiovascular disease. Because remember, women have less cardiovascular disease than men until around age 50. And then it comes close to it, and then at 60, it robusses it and surpasses it.
I think a lot of people don't know that.
No, I know. And it's a silent killer, so women don't worry about it. If I ask 10 women, what are you most afraid of? 9 will say breast cancer, and maybe 1 will say colon cancer. But nobody says heart attack, stroke, heart disease, because they don't picture it as suffering and pain, but it's the #1 killer of women. So if we could slow that artery clogging down, right? We can really prevent heart attacks, strokes. We can prevent the dementia that happens more to women than men. Alzheimer's,
More women.
yes, 2 out of 3 Alzheimer's patients are women.
Oh, I didn't know that.
Yes, so that's a women preferred disease, meaning more women than men get it. And then some diseases like endometriosis are only women.
Sure.
So we could literally be attacking all this osteoporosis. Again,
That's a huge one.
it's not a disease people worry about till they're old. They think that's for old women.
Right.
But guess what? It's very genetic based. So if your mom lost height and had a hip fracture at 60, you were a setup for it.
It's so true.
So by keeping the ovaries alive, we could delay all that indefinitely.
Wow.
I mean, that's like mic drop.
It is mind-blowing. Right?
Yeah.
It seems like
We're not
science.
far from it.
No, it seems like science
5 years away
fiction
from it.
to people, but it is a real scientific possibility.
Yeah. So I'm super excited by some of the science out there.
Really exciting.
You mentioned weight management.
Yes.
And I do want to say that the GLP-1s like Ozempic and Wegovy, those were actually invented 18 years ago. They're not new. They're only new because Hollywood has
Right, how we're using them.
Yeah, and now people come in every day saying, I want it. And they are life-changing. They're phenomenal. So I'm a huge fan. But they've been around for 18 years.
Wow.
If I were really an early adopter, I would have started using them 18 years ago. But I started using them about 11 years ago.
Wow.
So I have 11 years of experience with them, which helps me feel comfortable and confident working with people. So I really don't like the idea that now you can get them online because people just keep getting bigger and bigger and bigger doses, and they come in and they've lost the weight, but they look unhealthy. They have not built lean muscle mass and they're not healthy. So I really urge you, if you're considering doing a GLP-1, do it with a doctor. Do it with a nurse practitioner, someone who really understands them and who's been using them for a while.
Yeah.
In our practice, we really work with your lean muscle mass, your percent body fat, much more than what you weigh, so that as you lose weight, you're doing it in a really healthy fashion.
Yeah.
I think that's really important.
It's so important in this day and
I
age.
want you healthy for a long time.
Right. And that's what your practice is about, right? It's about keeping us healthy for as long as we
Yeah,
can be.
exactly.
So-
It's called health span as opposed to longevity.
Right.
We don't want you just to live to a high number. We want you to stay healthy longer. And we know that women actually don't. They go to fewer doctor visits. They tend to put everyone else first, mostly kids and others. And they are dismissed sometimes. So please don't accept that for yourself.
No, women should not accept that. No, I don't. I'm fortunate. My mom was a nurse. I learned a lot from her. And I've been fortunate to be a part of your practice.
Oh, well, I've loved having you. Thank you so much. Thank you for having me.
Thank you for being here. I'm so grateful that you took the time to share all this information. I'm certain there's a lot of things that people had never heard of before. So you're sharing such valuable information. It's empowering to women and to their partners to have this information, whether they're not yet perimenopausal or even if they're postmenopausal. I personally would urge everyone to pick up this book. I thought I knew a lot and I learned so much. And it is really life-changing when you can understand everything about women's health, women's sexual health, and what happens to women over time. I felt very supported and empowered reading this book. I know other people will. And I thank you for all of your groundbreaking work, all of your research, and the way you help women every day. So thank you.
Thank you so much. It's been great being here. I give talks all over the country and in other countries. And so you're really the first person in the community to say, let's publicize this in the community. People locally should know. And now that we've done this, I thought, oh my gosh, of course, I should make sure the community knows about this. And I do think the book will be really great for men and women to read. And I've been so touched when men reach out to me and say, my wife read it, but then I took it and I'm so glad I did.
Yeah.
So I think
that's important. It's not just for women to read. It's definitely for their male partners. There's a lot to learn in there. So.
Yeah. Thank you.
Thank you for being here. I hope you found this conversation as enlightening and as empowering as I did. Dr. Maryann Sophocles shared a wealth of insight into topics that are too often shrouded in silence, from menopause and hormonal changes to the emotional and physical facets of midlife intimacy. Her perspective reinforces a powerful message. Women are not broken or just getting old. Rather, it's our healthcare system and societal taboos that have really failed to support them fully. Conversations like today's help to break that silence, replace confusion with knowledge, and remind women and their partners that they're not alone on this journey. As someone who has followed Dr. Sophocles' work closely and who's read The Bedroom Gap myself, I can attest to the depth and clarity that Dr. Sophocles brings to these subjects. It's one thing to discuss these intimate topics in theory, but hearing her personal, compassionate approach, both in our interview and in her writing, truly makes the information accessible and reassuring. I'm really grateful for how openly she addressed questions that so many have been afraid to ask. Once again, I want to thank Dr. Sophocles for joining me today and for the dedication to reframing women's midlife health with such warmth and expertise.